Hello and welcome to What Would Larry Do? I am Dr. Ann and I'm here with Larry Helwig.
Hello.
Good afternoon.
Good afternoon.
It's late in the day.
Very late.
We're used to mornings and he had to stop off and get his coffee before he came in because, he's missing his afternoon nap.
Absolutely. Without the nap, I got to have coffee.
But I'm not going to lie, I probably should have gotten some because the podcast was starting and I forgot what I was going to say. Even though I say the same thing every time.
End of day. That's what happens.
Well, we've got a fun topic today. Today we have our guest with us, Dr. Jennifer Haley. She is a board certified dermatologist for the last 19 and a half years. She is an expert injector with dermal fillers and neuromodulators, as well as a trainer for dermal fillers and neuromodulators. And she's joining us to talk about injection safety today.
Yay.
Hi, happy to be here. Always great to see you both.
Yes, so good to see you. I know. I feel like, you're gone for the summer, so we don't get to see you all summer long. So I feel like we're finally getting you back now.
Yeah, you're suffering up in the mountains. Jeez.
When is summer over, by the way? It's still like 100 degrees out there.
I know. It's starting to calm down, though. For everywhere else I go, I've had to start bringing sweaters because, I still travel all over. And I'm still telling other people, they're like, isn't it hot in Arizona? I'm like, well, it's calming down. It's only 100.
It's brutal.
Sounds terrible.
Early morning wake-up. So yes, it is very late for us here.
Yep.
3:30.
Wasn't it Pakistan that was 135 degrees?
Oh my gosh. Like how?
Like a number of days in a row?
Yeah.
It's like, we have nothing to complain about.
No. I'll take 103 any day over that.
Yeah.
So
I
good.
know. Fortunate we have air conditioning and, many other things to make us comfortable. So
Yep.
Yeah, so either way, today we're going to talk about injection safety. There's a lot of popularity on social media and just in general with dermal fillers and neuromodulators. So neuromodulators are, of course, Botox, Dysport, Xeomin, and Jeuveau, and we'll talk about the new one as well. And then we'll talk about dermal fillers. So I want to kind of start with the neuromodulators because that for me is an easier section to talk about as far as what I would consider very minimal complications. So we'll kind of dive into that where these are very safe and easy to do. We have a couple before and afters that we're going to pull up. And I feel like neuromodulators, especially for us, is one of the gateway drugs that we get people into our practice with.
Use it all the time with everything you do, and it becomes very comfortable. Mm-hmm. People like it. It's an easy sale, and it is a gateway, without question, yeah.
the number one procedure in the world for a reason. It's so easy and you get great results. So it's very, very easy to bring on, and it's a very easy thing for people to start with. And in addition to topical skincare, of course, which everyone should be doing.
Mm-hmm. Yeah, you can see some of these before and afters for the frown lines, really getting rid of those, for the crow's feet, those smile lines around the eyes. And if you notice, everybody still looks very natural. So that's one of the reasons why they're super popular, as well as the forehead lines. So these are top areas that are all FDA approved with these different products that people can treat that can really prevent aging, but they'll still look like themselves, which I feel like is, what a lot of people want. They don't want to look overdone or plastic or have somebody know that they had something done.
Yeah, and we've really changed as the professionals who do these procedures. We've changed the way we've done them over the years. So initially, I think we were chasing lines, and we were all about getting rid of especially the frown lines, those angry lines between the brows, because, they really can make you look weathered and heavy and older just when they stick there. And I think we did too much initially, and we were giving people that frozen look and then the Spock eyes. And we've become more modest and more natural with the way we've done this over the last 20 years, where it's all about balance, and you still want to move so that you have expressions and people understand you and can read your micro expressions, but so that you don't move so much so that you form permanent lines that are there.
Yep, exactly. And for neuromodulators, really the main contraindications are pregnancy, breastfeeding, the 4 rare neuromuscular disorders like ALS, Lambert-Eaton, Guillain-Barré, and of course an infection in the area that's to be treated. So overall, it's pretty safe and easy for people to do it. And I think that's why it's so popular as well.
Mm-hmm. Exactly. I agree. Definitely not in pregnancy. I don't treat breastfeeding women.
I don't either. No, just because there's no studies to prove that I won't migrate. And even though to be honest, I highly doubt that it would migrate all the way into the breast milk. I don't want to be the one who finds out that it does.
Exactly, exactly. And there's a reason, why we can't give babies honey before the age of 6 months, because
Yes.
there is botulism toxin in honey. So
Mhm.
we don't really want to introduce that into a mother that's providing milk for the baby as well.
Yep.
It's not worth it.
Yeah.
We got through pregnancies without it. So.
Yeah. And in reality, if you're that concerned about it, then cut the baby off and put him on formula. Let's not risk baby death, finish breastfeeding.
After 16 months, I'm like, okay, I need my Botox again.
Yeah, I have women who come in who've been my long-term clients, and they'll show up and I'll be like, I knew you were pregnant and you're probably breastfeeding. And they're like, she's cut off or he's cut off or whatever the name is. I'm here. I'm ready to go. I need my Botox. I'm like, oh my goodness.
If you're one of those people, just don't worry. Feed your baby breast milk and we can catch up later. So.
Yeah. But, so other than avoiding those, main contraindications, I think one of the most feared complications of any neuromodulator, whether it's Botox, Dysport, anything else, is the eyelid droop.
Mm-hmm.
So let's talk a little bit about that. How does this one end up happening? Oh yes, look at that photo.
Whoa.
That was the Instagram famous photo.
Yeah, not good.
So the good thing about these procedures is they're not permanent. Mm-hmm. The bad thing is they're not permanent, but when you go to someone who is an injector, they need to be an expert injector and understand the anatomy of the face and where they are deliberately placing this protein, this purified protein to weaken muscles. If it's placed into the wrong muscle, what's going to happen is it's going to cause that droop, right? So that's what we don't want to do.
Yep. Yeah, and we have a face sheet that has all the muscles on it that we pull up. A lot of us use this for actually charting, but this is exactly it, where everybody has to learn where the muscles are that they want to treat, like the glabella complex or the orbicularis oculi, and then avoiding the ones they don't want to treat, like the levator palpebrae, or the other one that we'll talk about, the depressor labii inferioris. So you're right. This is all an anatomy lesson. That's why I always call the neuromodulators like a science. As long as you know where the muscle is, you know how to isolate it and inject it, then you can avoid complications.
Exactly. So going to someone who really knows what they're doing is important. And for anyone who's an injector who's listening, one of the other things that I've inadvertently done over the years is I've avoided, causing the eyelid droop, but I've still inadvertently made the brow very, very heavy by going deep on my lateral corrugator injection and actually hitting the frontalis. And we know that the frontalis is really the only muscle that elevates the brows. So less is more when it's there, because we don't want to have that heavy, angry baboon look with, a weakened forehead.
Yep, absolutely. So yeah, it's learning to identify where the tail of that corrugator is and getting it into the right zone. And also, you're right, if the injection's too deep there, that's where it can also run down the frontal bone and hit that supraorbital foramen.
I think you made a very good point about, a specialist or someone who's got some experience. The nursing class that just graduated, I know out of one school had 195 new nurses. And there's a lot of schools that just graduated. Well, a lot of the nurses are going and taking courses to learn how to do injectables. And then I hear that within a very short period of time, they're teaching. And I'm thinking, this is not a good idea. And having done that years ago, where I was trained literally by 3 different people who were really very, very good, if you're not doing this all the time and you don't have the experience, you probably shouldn't do it. And that's why I stopped. I mean, it doesn't make sense. Too many things can go wrong, especially when you get into dermal fillers. Mm-hmm. And I think that's such an art and science combination. A lot of people don't have that. And I don't think just because it says RN or whatever it says make you an expert. I think you really do have to put in the time, the knowledge, and get the experience. And I'm glad you mentioned that.
Yeah, I think that's such a good point, Larry. A lot of people, consumers in the United States, we believe that if somebody is doing the procedure, then they are qualified to do the procedure. Yeah. And unfortunately, that's just not the case, especially because state to state, the rules and the guidelines are very variable. In some states, it's only an MD, and in other states, even aestheticians can inject. So it's very variable from state to state. So you want to do due diligence and, do your vetting of your injector. People will often ask, what's the best product? There's 4 currently FDA approved. There's a 5th one called Daxxify that was just FDA approved on September 8th. And people will say, which is the best one? Well, I think those of us who use all of them, who've used all of them over many years, we can give you good results with any of those products. So it's more about the injector, not about the product.
Yep. I totally agree with that because I can make any of them work. And I do find in some patients, maybe one works slightly better than the other. And in other patients, they're all identical. But in reality, when we're used to injecting and we have that knowledge of it, you can take any of those products and make them work really well. Although, exactly. I'm excited to try the new one because supposedly this one is going to last longer. So
it's interesting. I mean, I was reading a little bit about the history of it because I love learning the history of how these things are created, sort of how Botox was founded by Jean and Alistair Carruthers, because for those of you who don't know, Jean Carruthers is an ophthalmologist in Canada, in Vancouver, and she was injecting for blepharospasm when you get those little spasms in your eyes. And one of her said, I want you to inject here. And she said, but your spasm isn't there. And she goes, yeah, but when you injected over in the other spot, my wrinkle went away. So she had an aha moment and then approached her husband, who was a dermatologist, and said, hey, you've got the wrinkle patients. Let's play around with this and see if we can make some magic happen and smooth out some wrinkles. So with the Daxxify, it was initially researched for topical use because there's many people that are needle phobic, even though the needles that we use for these injectable neuromodulators, these purified proteins, I hate using the word toxin. So even though, we use very, very thin needles, as thin as your hair, some people are needle phobic. So they were using a cream, and the FDA said, you know what, this is going to get absorbed. You need to do an injectable study. And then when they were doing the injectable study, they found that people were getting really great results and longer lasting results with this product. So I'm excited to start using it too. I don't know when we're going to have access to it, but it's nice to have something else in our armamentarium to use.
No, I agree with you. I'm excited to try it out too. I always like to try out new stuff and just see what happens, see if it's different, if it's better. And if not, it's more stuff that's out there that we can use and use in different ways sometimes.
Yeah. And I always like to believe maybe there'll be more competition so the prices will go down. That doesn't seem to be what's happening.
No, it seems to be going the opposite direction. Absolutely. Well, before we jump into dermal fillers, because that's the part that I really want to spend some time on, the last thing I want to talk about, so eyelid droop is the biggest fear, but I think a lot, and I just saw a patient the other day. She's my patient, but she was not treated by me. She goes back and forth between a couple states that had that crooked smile. So let's pull up. Yep, there it is, the crooked smile. So, Dr. Haley, how does this end up happening with our patients who are getting neuromodulators?
And I see this every time I turn on the LA news. I'm just going
Oh, gosh.
I don't even think people realize, because think about it, when we see ourselves two-dimensionally, and we see ourselves often not in movement, right? Well, now on Zoom calls, we see ourselves in movement, but before then it wouldn't be in movement. It would be static. So a lot of people weren't even aware that they were even looking this way. And what happens is when we're treating crow's feet, right? Sometimes have little creases that go down your cheeks. I don't know if you could see some. Yeah. When you smile real big, you could have little creases that go down your cheeks. And if you start chasing those creases that go down the cheeks, there's a strap muscle that connects the corner of your mouth all the way up to your cheekbone. So inadvertently, you can be weakening that muscle. And then instead of being able to smile up, you smile down.
Yep.
So not permanent, not enjoyable.
Yep. Nope. That's for sure. So it's like the zygomatic muscles are the ones that you have to be aware of. And then also I see people when they're trying to do the depressor angularis oris and it migrates over to the DLI muscle and hits that one too. So that's the other zone where it's that neuromodulator migration to a muscle that you don't want it in.
Yeah. So when you smile, you get more of a lower look. I've done that to myself. So is people say, oh, I'm such a great injector. I haven't caused any side effects. Well, if you're a great injector, you have seen all the side effects.
Oh, yes.
To be able to see them. Yep. And then you how to handle them better, right? So it's just a matter of numbers and obviously collaborating with people like you and, other people that, can give you some insight and teach you along the way so you don't cause problems. But Yeah, having side effects. I mean, I think in the package insert for Botox, it's somewhere around 3% of an eye causing eyelid droop. I haven't seen that high of a number.
Yeah.
I've had it happen twice, and I know it's because I was not paying attention because both of them were really good friends of mine, and I was not paying attention. I know. So I
Whoops.
think the anatomy, you can get it really close to zero.
Yep. I agree with you. And you're right. It was a plastic surgeon who once told me that it's a numbers game. The more procedures you do, the more likely you are to end up with a complication. So even if you are really good, and it's like you said, it's just making sure you're always paying attention and always trying to do your best, because the more procedures you do, the more likely you are to come across complications. And I've definitely come across complications both with, neuromodulators as well as dermal fillers. And that's why I really wanted to bring it up. I think it makes, both you and I better teachers as well, because we have had those and we can share our experiences and say, okay, I did this once and here's what I learned on how not to do it again.
Exactly. Yeah, exactly. And that's always the goal, is to have people learn from your mistakes and not have to relive them. I just want to take a step back, and I know you have a really astute audience, and you've discussed this in previous podcasts. But for people that are listening for the first time, so I have a lot of times people will come in and they'll say they want Botox or Xeomin or Dysport or Juvo or now Daxxify. They want a neuromodulator. And then I say, oh, well, what are you looking to do? And they might point to a nasolabial fold, or they might point to, sunken in under the eyes. So I just want to make it clear that these products, these neuromodulars, the way they work is they weaken muscles that form lines. So it works really well for frown lines, because if you don't want to frown, you can soften those lines in between your brow and raise the brow a little bit. It can help with the forehead muscle to help soften those lines. Now, if you put too much in there so you don't move the forehead at all, it could lower your brow. So we have to balance the look with the desired softening of the line. And it works well for crow's feet and then other areas like neck bands and things like that. But it doesn't revolumize. And that's why we're going to talk about dermal fillers.
Yeah. No, and it's good. I'm glad you brought that up, because that is an important point. And Larry is the one who does a lot of our consultations in our office. And I think he comes across that a lot, where patients come in asking for certain things and it's not what they need at all. They know that they want a desired outcome, but they actually don't know how to get there.
They're using Google as their source, and they get some information, and they come in and they're so confused about what they're talking about. It's like, are you kidding me? But I'd also say that if you do make a mistake, do it at the time where you've got an event coming up, like Halloween.
Oh gosh.
Yeah,
Can make it part of the costume.
Make it part of the costume somehow. Use it for fun that way.
Actually, before we switch to the dermal fillers, I have a funny story on that. Talking about neuromodulator complications. So I was early on in my career, and I was treating a man who was bald, and I was doing his frontalis. I did glabella frontalis. So I did the frontalis just straight across, just right where the lines were. And at 2 weeks in, his wife brought him in, and she's like, okay, can we fix this? So as you know, as an experienced injector, the frontalis comes up to 2 peaks, and the peaks a lot of times are dormant because you're using the lower part. Well, this wasn't moving at all. And when he went to raise his eyebrows, it pulled the skin up into 2 little horns, right where the peak of the frontalis was. Oh my gosh. I'm not going to lie. I laughed out loud. I was like, I've never seen that. And they were both a very funny couple. She said, if this was Halloween, I would make him be a devil, but it's May. Like, we got a while to go before he can pull off that costume.
At least you know the recipe for next February.
Oh, yeah.
So 2 weeks before. So if you're getting married this weekend, don't come in on Thursday for Botox.
Yes.
Fully kick in. And then I'd give it 3 weeks in case you need a touch up,
Yeah.
But I mean, go back to the consultation, Larry, because so the reason, and this is really important for people to hear, they always say, if all you have is a hammer, then that's the only tool you use, right? So I send all my laser patients to you, because we all know that lasers are pretty expensive, and most practices usually have 1, maybe 2, maybe 3 lasers. So they will make those lasers work for somebody's condition. Whereas Clearskin Institute, you guys have, I don't know, dozens, maybe 50.
Yep.
Yeah.
20 some.
Yeah. So, I mean, not all vascular lasers are created equal. Not all pigment lasers are created equal. So when you have many options, then the person you're doing the consult with, or the practice you're doing the consult with, if they have many options, they're going to get the best option for you, not just the one option they have. So just
Right.
keep that in mind in the back of your head, especially if you're not getting results. Think maybe the treatment isn't the right thing and I need to go somewhere else. So
Yep.
same thing goes with fillers and neuromodulators. I mean, there's many different types and they all do different things.
Yep. Yeah,
That's
which is
right.
good because, a lot of patients who do come in for the consultation actually have volume loss. That's a very natural part of aging, is the lipoatrophy of the face. And that's why dermal fillers are so popular. And even though we have a lot of laser equipment in our office and Larry does the full consult to help them talk about skin, I'm still really big with injectables and dermal fillers because if you have volume loss, you need to replace volume to get that face back to where it looks more youthful. However, this is where I really encourage people to get proper training because out of the injectables, it's like, yes, that Botox picture with the drooped eyelid was a little scary. However, in a couple months it wears off, you have 0 permanent complications. Dermal fillers have some scary complications that can go along with it. And sometimes I don't think patients are aware of that when they're signing up for it. And I think it's our job to not only inform them of it, but then do the best safe practices as possible to avoid these complications.
Yeah, I agree. And I bounce back and forth between Scottsdale and then Park City. And
Yes.
I mean, I'll do Botox in my kitchen in the spa, and people at least once a day say, "Can you do a little filler?" And I'm like, "Oh no, I'm not doing filler in this setting. That has to be in a medical office with nitropaste, hyaluronidase, the whole kit, just in case. Because all you need is that one time where you're in an artery and you can cause a permanent occlusion of an artery, and now you've cut off the blood supply to someone's skin, and it's not pretty. And I'm sure you're going to get there.
Oh, yeah.
Sorry.
Yeah. Well, let's start out by looking. We've got a couple videos of before and afters with dermal fillers, as well as a before and after for dermal filler pictures. So these are some videos that are done with some of the Restylane products for treating like nasolabial fold, marionettes, smiling areas, lip lines, where people can be done and look very natural, where she looks more youthful after being treated on the right-hand side, but still she looks very natural. So I think that that's one of the misconceptions out there with dermal fillers is that, which we are going to talk about too, the overfilled faces that we've seen happen. And I think that's very avoidable in this day and age, where you can see this lady over on her right-hand side is after she's been treated, her nasolabial folds, smile lines, marionettes look much better. She still looks very natural. So when there is actual volume loss, I think can be a wonderful treatment. For me, it's just really getting into what are some of these complications. There's another before and after. And what are normal complications versus ones that should be avoided or, that injectors want to be very well trained on in order to do. And, as we dive into some of those complications, the first one I want to talk about is just bruising. So.
Normal. So I love those videos because they're so different from how the companies were advertising 10, 15 years ago when Restylane launched, where we just showed one small area of the face and we were chasing folds. And now we're really looking for balance and we're making sure that the face looks natural with movement and without movement. So I love that. I love that perspective. Bruising, I tell everyone expect bruising for 2 weeks. I try to offset it by stopping fish oil, any blood thinners, obviously aspirin, ibuprofen, vitamin E, ginkgo, all that stuff for a couple weeks beforehand. And then I'll give people arnica and bromelain as well, because I find that helps with bruising and it helps with just swelling overall. But I tell them expect to have bruising for 2 weeks, because even when we're going to place the filler, if we don't hit an artery, which we never want to hit, there's inadvertent vessels everywhere. That's what supplies oxygen and nutrients to our skin. So we can inadvertently hit them and they can cause a little bit of a bruise. But if you do those other things, instead of being a large bruise, might be just a small little bluish purple spot that can be covered up with makeup.
Yep. Yeah, and we have a bruised lip photo here. It's very normal, especially doing lips because they are so vascular. A lot of times patients will bruise. And I agree with you. And, some injectors are like, oh, if you bruise them, you lose them. And I do my best not to bruise people. But it's like you said, we are injecting with needles and there's tons of tiny little capillaries and, minor vessels that if we accidentally hit them, they're going to bruise, but it's not a big deal. So it goes back to what you were saying too with the neuromodulators, like coming in 4 days before your wedding, this is not okay for dermal fillers. Besides bruising, you can have swelling and things like that. And you just want to make sure that you give yourself time to be able to heal from that. Now, the other one you brought up, though, is the arterial occlusion. So I do want to talk about vascular occlusions, whether it's artery or venous. These are the ones that do need to be avoided. And this is where I think anatomy and proper dermal filler training becomes so important for any injector out there. And we have, actually have a photo of an occlusion that led to blindness from a dermal filler. So we'll bring that one up. This is every injector's nightmare, is getting that occlusion that's going to end up in reading back to the, either the ophthalmic or the retinal artery and leading to blindness. So yes, so know your anatomy, right?
Again, a good reason to go to someone experienced.
Yeah, a lot of times people might be in their late 50s or early 60s and they haven't done any procedures, and now all of a sudden they want everything. So they may have some deep lines between their brows, and I'll say, okay, let's start with the neuromodulator first. And it's not going to remove that line at rest. I may stretch it out and say after a year of treatments every 3 months, it can get to this point, but you still may have a little crease there. Are you okay with that? And sometimes people will say, no, I want the filler there now. And then I explain to them the risk of blindness. Mm-hmm. Let's start something more conservatively. It took 60 years to get to this point. Let's give it a year and see how much improvement we can get with something more simple and lower risk before we start jumping to things that are risky.
Mm-hmm. Yep.
And it's not that we don't do it. We just know where to place it pretty superficially, what products to use. And it's not just something we grab just easily, right?
Yeah. Well, yeah. And I've got that facial artery sheet to pull up too. I think one of the biggest things that, when you and I are training people is going through this, knowing where that supratrochlear artery is, knowing where the facial artery and its branches that lead to the angular artery and the different arteries along the nose where they all connect together and lead back to that retinal artery. So there's all these different arteries along the face. And it's like you said, knowing your anatomy and knowing that depth. They're in different places, but where even expert injectors like us can get into trouble is that people's faces don't always follow the textbook. And, even though we know where that, supratrochlear artery should be, that a lot of times will lead into that zone, it doesn't mean that it's going to be there. And so when I talk to injectors, it's two things. For me, in my practice, I choose to stay out of certain zones where I know they're going to be high risk. Like I know that, the liquid nose lifts are all the rage on social media. It's actually one of the things I don't do in my practice and I won't teach because I know where those vessels are supposed to be and I know that I could avoid it. But that's when, if you do it enough times, you can get that one person whose anatomy does not follow the textbook and you get that arterial occlusion.
I agree with you. And also patients who have had other procedures that haven't disclosed that with you. Yes. And now their anatomy is not in the right place. So I feel like it's Russian roulette, the liquid nose.
Yeah.
It feels to me like that 8 shot, it's going to get me, Yeah.
I know.
No, there's so many other home run areas. Mm-hmm. And I think when we're doing these procedures, it's about accentuating someone's positives, not focusing on the one negative often. So.
Yeah, but one of the areas I do want to bring up too and show some photos is let's talk about nasolabial folds, which is this area coming right down here. This was the first FDA approved area for filler. It was nasolabial folds, and this is an arterial occlusion in the nose from being treated in the nasolabial fold. So it started in the nasolabial fold, and that's the progression of it as it goes along where it first started. So you can see where it was the blanching, there was no blood flow, then it leads to the necrosis of the tissue, which means the tissue is dying or it's eaten away, and then it eventually resolved from there because I'm sure this patient was being treated by the injector. So nasolabial folds is still something that I treat in my practice. For me, I know where that facial artery should be, but because I also know in a lot of people that the anatomy doesn't follow where it is, I tend to use cannulas in this area, which we'll talk about a little bit later in this presentation. But there are techniques that you can use to avoid arterial occlusions. And I really feel like in super dangerous zones, cannulas is one of those benefits.
Mm-hmm. Yeah. And also, I mean, our body is pretty amazing because our body puts the arteries really deep to protect. If we fall, right, we're not going to hit the arteries. So in that area, I don't go deep enough typically to hit the artery. The cannula is very beneficial. And then the other thing is being a gentle injector. So
Yes.
being aware of the fact that we are injecting a foreign substance into the body, looking for signs of how the body's responding. So a couple things I'll ask the patient: does it feel the same as the other side? If it feels a lot more painful than the other side, something's wrong. If I see blanching, which basically means the pinkness turns white. If I see whiteness of the skin, I get out of there right away. If I inject a whole bunch, now I've really caused some damage. If I injected 0.1 cc's, very, very minuscule amount, it's not going to cause that type of trauma. So I'm looking for feedback from the patient. I'm looking for feedback from the skin. I'm injecting slowly without causing a lot of trauma. And these are the things that you want somebody to do. It may seem simple, but it's like watching someone do yoga. When they're really good, it looks easy, right? And that's what you want.
Yep, absolutely. And, in the other areas and certain zones that we may treat with actual needles versus cannulas, let's say like cheeks and chin, when you're actually going deep where some of these arteries can be down to the periosteum, it's important to do your aspiration. And I know there's debates on it out there, people saying that it won't pull up or it will. Well, in my experience with products, once you get in, especially to an artery, there is enough force with that if you are actually holding and aspirating for a second or two, it's going to shoot up into that hub. And I've been in zones where I've inserted a needle and a flashback has come into that hub, and you're like, oh, just back out, don't inject, hold some pressure because they're going to have a hematoma. But it's really, like you said, taking the time and paying attention and watching for those little keys. And if you are on bone and you're going to be depositing a bolus, make sure you aspirate before you do.
Yeah. So we're not trying to freak you all out here. We want you to realize that there's a foreign substance that's being put in the body. Now, it is similar to a natural substance when you're using hyaluronic acid that's already in the body. So the chance of allergic reactions are small, but it's still a foreign substance. So you need to make sure it's very sterile, it's clean, and we're not going into areas we don't want to go into. There's an art with it. It's more art than science, to be honest with you.
Mm-hmm. Yeah. And, yeah, no, that's a good way to put it. There really is more art than science. And I don't want people to be scared of it either. I love doing fillers. Larry recommends it to almost all of our patients who come in with volume loss as part of their treatment plan. So I think these can be done very safely and trying to minimize complications with it.
And I love that you do fillers on me, Anne.
I love to have fillers done on myself as well. I'm not going to lie. I just had some done not too long ago.
We all like them.
Mm-hmm.
One of the things that is not part of the general discussion, but maybe should be, is the patient who comes in and kind of tells you what they want. I want 2 syringes. I want this fixed, all of that. And the challenge sometimes when you know that's not correct, that's not going to get them what they want. We have a device, it's a 3D camera system, and you can actually put 2 syringes in like they're asking for, and they will see it does very little, but 3 makes a nice difference, 4 is the answer, that type of thing, where you can actually show something. And in some cases, I think that's important because patients think they know, they don't always know. And sometimes they're wanting too much, and you can actually show how ridiculous that's going to be as well. So sometimes in the consultation, you can change things a little bit and get them a little more in line with what's necessary.
Yep.
I love that you have that. I take this approach where I want their friends, them to be like, did you get a haircut?
Mm-hmm.
Did you go? You look really good, but not what did you have done, right? We want people to notice that we're slowly looking better, yet nothing's really indicating that something cosmetic was done, so that in 2 years you look very different, but it's a slow, gradual reversal to where you were maybe 4 or 5 years ago.
Yep.
Right.
No, I agree. And that's something that we really try to promote in our practice. Yeah. So, well, before we jump onto some of the other complications and we leave the vascular and arterial occlusion complication area, I do want to show our photo of the difference between a needle versus a cannula. and kind of talk about where cannulas have come into the filler market in the last 5 to 10 years or so. So the top one's a needle. As you can see, it has a very sharp point, and the bottom one is a cannula with a rounded tip. And so for any of our listeners out there who are not as familiar with these, cannulas are a blunt edge. So think of the needle as the knife and the cannula as the spoon. And when cannulas get up to a large enough size, not meaning huge, but in different needle gauges, so like a 22, a 23 gauge, there's actually a statistically significant difference in between the amount of pressure it would take for a needle to pierce an artery versus a cannula to pierce an artery. Meaning that if we're an injector and we're injecting with a cannula and we come near an artery or a vessel, we will feel resistance, and you're not supposed to pop through in that. You should be able to work around it so that you'll never end up with the cannula inside the artery depositing that bolus of filler to do it. So that's one of the ways that you can help to avoid arterial occlusions in dangerous areas, is by using a large enough cannula where there is that statistically significant difference in the amount of pressure it takes to pierce a vessel.
Yeah, I think of it as like, Chuck E. Cheese or one of those places where you have all those balls. Mm-hmm. Like or just imagine balloons, if you take your arm and you punch it through, it's going to move all the balls aside, which are the arteries. But if you take a knife and you stab it, you might pop one of the balls, right? Yep. So the needle is more likely to pierce the vessel, whereas the cannula is more likely to kind of push it aside. But going back to your picture, I don't want people to think that the cannula is much longer than needles, because we do have some needles that are longer as well, and longer should not be more intimidating to you.
Yeah. And it's not necessarily that it's being inserted all the way either. It's just to have that durability with it. Sometimes we need the longer cannula. So yeah.
I had a hard time learning cannulas because I was so comfortable with needles, because, doing biopsy, we use needles at least 30 to 50 times a day as a dermatologist during procedures. And I had a hard time with it, with the 15 blade or the 11 blade usually we used, and then getting it in there. It was a slow learning curve for me. It was hard for me to start learning to use, but short-term pain for long-term gain and lower risks of problems, I definitely like using the cannula for certain areas.
Yeah, me too. And I'm in the world, because there's injectors that are divided. There's some who are only cannulas, some who are only needles. I kind of live in the middle, where I prefer cannulas for certain zones, especially my super dangerous zones, and I still prefer needles in other zones. So I'm one of those that when I'm doing a lip, I still prefer a needle in the lip. I'm extra careful with what I'm doing, but the way the lip turns out with the needle in my patients, I feel like has a better look than with a cannula. So I'm still going to use a needle in that zone.
I agree. I feel like the cannula looks a little sausagey there for me as well. My technique, there's always something to learn, right?
Yes. Yeah. No, I love going and learning. Well, as we get out of that kind of complication, because I could have an entire podcast just on arterial occlusion, I also want to talk about some of the other complications that can happen with filler, one of them being lumpiness. So we have a photo of lumpy lips that show up. And, anytime this happens, this is injector dependent. So this means that your injector did not do a good job if they leave you with lumpy looking filler. So
when we teach, and I'm educating the students, I'm so torn, because I show them this, or the little beading from going really too superficial or choosing the wrong product even. And I almost would rather have this result from someone who is new, because we could easily dissolve this with hyaluronidase, versus someone going too deep and hitting an artery, right? Mm-hmm. So if you had to pick your poison, I'd rather have this, because it's completely fixable over, the arterial occlusion, which can be really, really damaging.
Nope.
And
I agree with you. And so this is more of a technique dependent, but this is completely fixable. So we're starting to move into some of the more minor concerns of it. But I agree with you. This is something that we can take care of. However, you should still get the proper training so that you're not sending out patients looking like this, because then it's a hand-holding process over, a couple weeks of helping them look better and work through it. And now they're scared of it, or there's all kinds of negative things that happen. So our goal is to get trained properly so we don't leave them looking lumpy anywhere on the face.
Exactly. Yes. Proper depth, right?
Yes.
For someone who makes the mistake and they get a lumpy, lip out of it, and you correct it, how long does it take to see the improvement? I mean, is it like right away?
A couple days. Yeah.
So patients out there, this isn't a long-term thing.
Mm-hmm.
You can have it fixed, and within a couple days, you're back to normal.
Yeah. And it may take a few visits, and each visit, it's going to take a little bit more time, but it's a relatively short period of time that you can correct that complication.
And it's an easy procedure to do.
Yep. Injecting that hyaluronidase to dissolve that filler out if they were using a hyaluronic acid filler.
Yeah. So again, don't, as a patient out there, don't panic with all this. Go to experienced people, and if you get a little something like this, they can correct it. It's not going to be a big deal. And so, what we're trying to do is just cover all the possibilities so that you're aware and educated on it. And I think that's the start of everything.
Yeah.
And I would recommend that you go back to the person who did the injection, because they should know about it. I would want to know about it if this happened to one of my patients. Don't feel embarrassed. They need to know about it. And then if they fail to treat you and correct the issue, then you can go to someone more experienced, but at least give them the opportunity to recognize what happened so that they don't do it to someone else, and give them the opportunity to improve it.
Yep. I agree. And as we're on the subject of too superficial in injections, we also have photos of the Tyndall effect. So we have a couple photos that are going to pop up. So Dr. Haley, what is the Tyndall effect?
The Tyndall effect is so when we see things with our eyes, right? Mm-hmm. When something's very deep, it has the appearance of being blue, like if it's a blue mole, for instance. But if you have a foreign substance under the skin that is at a certain depth, it appears blue. Even though the product itself is not blue, that's just a tint of it because of the depth and the distance it is from the skin. I don't think I explained that properly, but
yeah. But no, you're right. And we showed both in a nasolabial fold and tear troughs where product was too superficial, and it gives that bluish hue. So if the product is placed in the wrong plane and it's too superficial, it's almost in the epidermis versus being in the deep dermal, the subdermal plane, it will give a blue hue. And I think the under eyes are one of the zones that this ends up happening a lot. And people end up with puffy bags that are blue instead of a filled in under eye, and it actually makes them look older.
Yeah, and I thought I'm not satisfied with under the eyes with filler, which is why I had you come on my podcast and talk about the PRF under the eyes, because that gives a far superior result. Because I feel like even if filler is placed properly, I'll see patients 2 years later that were treated by someone else in another state where they used to live, and it looked great right afterwards. And then 2 years later, now it's sagged down into almost their mid-face, and from a distance it looks like a line of like a blue blob, and we have to dissolve it with hyaluronidase, which we can get an immediate result with that. It's just a little puffy for a few days, and if you're allergic to bee venom, you can't really use it. So that's one thing to know.
Yeah, no, and you're right, because filler migration was the next on the list of complications, so those tear troughs lead right into it. Not only can it be superficial there and get Tyndall effect and get puffiness, which Larry earlier today said we could have a whole podcast just on bad tear troughs.
Yep.
Because I think the three of us have seen so many of those. Yeah. But the migration of the product there, again, if it's placed in the wrong zone and they're getting it into that orbicularis oculi muscle or in a zone where it's not supposed to be, that causes it to migrate. And you're right, it might not be right away, but later on, it ends up in a pocket. And I've seen people as long as 6 to 8 years post-injection from other people that have come in asking for their eye bags to be treated. And I'm like, I'm pretty sure that's filler. We had a lady not too long ago who was ready to have, Agnes in her under eyes. And I told her, I was like, let me try to dissolve that. Because it was 6 years later. She's not even seeing that injector. And lo and behold, it was a unilateral filler that was left from 6 years ago.
I've seen that last as long as well. Yeah. I mean, even though the label will have to advertise last 6 months, last 12 months, last 18 months, we see these things last longer and longer. So if you have one injection of one filler, you're not going to look the same 10 years from now than you would have looked if you had nothing. There is some sort of a collagen stimulation, some sort of a residual effect. It's not, I'm not saying it's permanent, but it lasts longer than we initially thought.
Mm-hmm. No, it does. And, the other top area that patients will see migration of filler is around the mouth. So It's the same thing. It goes back to your depth here where it may not be too superficial, but if they're injecting too deep in the lip area and actually getting it into the orbicularis oris muscle, that's where they're getting that migration where it moves up into the upper lip and it gives them that mustache lip look.
I think that's a tricky area because you go too superficial and you get bumps
Yes.
and deep. And then even though the placement might look right at the time of the visit, they go home and they talk and they chew. And if it's in that muscle, it's going to move and migrate. And I don't always have to dissolve those. Sometimes I could just take my thumb and my finger and smash it around to help it integrate into the collagen a little bit better.
Yep.
What do you find?
Yeah, no, it depends on how long it's been there, right? So it depends on what kind of filler they had used, if they even know that at the time, and then how long it's been there. But yes, no, sometimes I feel like it can integrate, and other times if it's pretty bad looking, I've had a few patients where I've dissolved it out and I'm like, let's just start over. I know that this is unfortunate for you, but let's get rid of it and start fresh so that we're not just battling it all the way along and having them continue to be unhappy.
Yeah. And I think there's over 15 fillers now that are FDA approved. So it's going back to, why having multiple lasers is going to give someone a better option, having access to multiple fillers, because sometimes it's injecting the wrong product in the wrong place.
Yeah.
Some fillers are meant more for other areas that you have to go to someone who knows what to inject in certain areas to give you the right look.
Yeah. Well, and that brings me to our next complication, which is nodule formation. So we do have a photo that's on nodule formation. So this can happen with certain products used in areas that they don't belong. So because there are different kinds of fillers out there, you just have to pick and choose. And again, I think that we could have an entire podcast on nodule formation with some of the stuff that's going on out there. So I'm not going to focus any particular, but the other important thing is we do have a lot of FDA approved fillers. Please do not go to injectors who are going to use some non-FDA approved filler in your face where we don't know what is actually going to happen. Yes, raise your hand over here. You, sir, what has happened when you have done that? And it was not me. It was not me.
No, it was a long time ago. It was stupid. And rather not talk about it.
Anyways, nodule formation in his nasolabial fold and chin area from using a non-FDA approved permanent filler.
Hence the beard.
Also, don't go to foreign countries.
But this was a filler from a foreign country. God. Oh yeah, let's give it a try.
Yeah, but yeah, you're right.
We've all
the foreign country thing too. It's just, if you are, make sure that it's somebody that's well known that's using good products. There are injectors in other countries that do great things, but it's not about being cheap. It's about being good, which will bring me up to some of our other photos that I want to show of just bad filler injection where it's either too much, or sometimes I don't even know what these people were thinking. If we hopefully have those photos. I have it. Yep, there's the lips. Those are the ones.
Whoa. Yeah.
I mean,
a lot of comments on that. Just,
go ahead, Larry. Go ahead.
Yeah, there's a vagina on her face. Really, look at that.
I mean, the lipstick alone was a horrible choice. But let alone the fact that I really don't think it's like you said, it's the filler pictures from years ago where they're focusing on a little spot instead of looking at her whole face. Oh my gosh. And she could have been a very pretty girl. And then this is tear trough filler. When you and I were talking about tear troughs, here is, again, an injection where they didn't put it in the right place, led to puffiness, and just led to a very, unsatisfactory result.
Yeah. I personally had that done. It was right after residency and I was at an ENT doctor. I said, hey, can you put some of that Restylane under my eyes? And he said, I should have known. He goes, oh, I've never done that, but I could try. And this is the beginning of fillers. It was Restylane. It was the only filler we had. And this was 17 years ago. And it was dissolved finally about 5 years ago, 12 years later.
Oh my gosh.
And not as bad as that, but if I was across the room, I could see a line of blue going across, and I just thought it was tired mom eyes, but it wasn't, it was filler. So.
Oh my gosh. I know. It's crazy how that happens though. And that's where too, I didn't even really get into that as a whole complication, but it's something that I wanted, to really talk about the real risks of it before we even talked about just bad injections and people not knowing what they're doing and willy-nilly. And it's not that I don't think that people should go for it. If you're a new injector and you want to get started, please seek out some quality training. Get some practice, and then as Larry always likes to say, then go do another training. Because then you've gotten to do a little bit on people and you've got to learn some things, and then you'll go to another training and you'll learn something even more. So it is an investment, but you don't want, these serious complications to happen, but nor do you want people to come out looking terrible and, having them tell people that you did a bad job either. So.
Walking billboard. So going back to that distorted face, I wanted to talk a little about filler fatigue because in certain areas, I mean, in Scottsdale, like when I go to the mountains in the summer and then I come back, I get a little shocked because I'm used to seeing, rugged outdoorsy mountain people and with no product. And then here, people get very distorted. And when you're surrounded by a wall of distortion, that becomes your new reality. So I know that often the companies will say, make sure you have them come back every 3 to 6 months to get their treatments. And these products build on themselves, especially with lips. I mean, you really don't necessarily have to have it every 6 months because that picture, well, I doubt it with that picture, but often like, one syringe is 1/5 of a teaspoon. It's not going to make you have crazy lips. It's going to be very nice and natural. But if you come and you keep every 3 months getting more and more and more, within 5 years, yeah, you will have lips like that. So it just take a step back and maybe look at an old license of yours and say, okay, that's how my face was when I was young. We don't want to have a distorted face where things aren't looking balanced anymore. And the term for that is filler fatigue. Like just enough is enough. Like, I think we've done enough filler. Let's look at some other things. Maybe we need a little tightening. Maybe we need some threads. Maybe we need something else. The filler isn't going to solve all the problems or all the issues with the way you're living.
Well, and I think a lot of people use filler as a tightening product. And, they're trying to tighten their whole face by sticking filler in it. And, as opposed to, filling in the hollow areas and things like that. There's technology for tightening skin and tightening the face. And I think, again, if all you have is a hammer, everything looks like a nail. And that, just like you said, this is what's going on in many cases. And I think they just keep putting filler and using it for more than its desired purpose.
Right. And I mean, a 15-year-old has a nasolabial fold. We don't want to ablate that. It's natural. But the reason it's standing out so prominently might be because there's laxity of the skin or you need volume in your temples. Oh, I think I do. No. Or something. There's a lot of other reasons. And that's why if you go to someone who can really look at the aesthetic face and provide some balance and some insight and some three-dimensionality, and especially if you have that kind of a device that can show you what filler can do versus what something else can do, that's where the magic is, where you look natural and ageless and everything we want.
Yep. No, I agree. And then just to kind of wrap up, basically for our injectors, it's really important to get good training, and it's important to know your anatomy. And if you know your anatomy and you're following safe practices like aspirating when you're doing boluses, and especially when you're down on periosteum, or using cannulas in dangerous zones, or in some cases, choosing not to inject the dangerous zones, especially if you're a new injector. And this is what I teach in my classes, because when I start out new injectors, I usually start them with cheeks, nasolabial folds, marionettes, and lips. And I tell them, until you're bored with treating these areas, you really shouldn't start to venture out to other ones. And don't be afraid to tell a patient, you know what, I don't inject that area because of the dangers, and I can refer you to somebody else, like a plastic or somebody else who is really well trained to do those things. Sometimes it's an expert nurse injector, an expert dermatologist injector, whoever it is that's really good, and just say, I don't do that, but this person does, let me send you to them. So, that's something that I encourage for new injectors, that don't just like your experience with the tear trough. Well, I haven't done that before, but let's see what happens. Sometimes not a good idea.
I agree with that so much, Anne. And we love to teach. I mean, all three of us love to teach, and we want to promote people to learn. We weren't born with this knowledge. We had to learn as well. And we just want you to learn right and learn safely and,
Mhm.
honor yourself and honor others in the process. And I also believe the best cosmetic treatment is a smile. So make sure you hang out with people who make you laugh.
That's right.
Larry's gonna have to put that in his lectures from now on.
I love it. Yes,
Yep.
that's good.
And then the last thing for injectors is making sure you keep hyaluronidase on site. So we didn't really get a ton into that, and again, that's going to be in a whole thing on its own. But hyaluronidase is the product that is used to dissolve hyaluronic acid fillers, which are the most commonly used fillers, so that if you do end up with an arterial occlusion, you have something right then and there. Just like Dr. Haley was saying, if people were to ask her to inject filler and it was, somewhere that she didn't have all these supplies, she would choose not to because she didn't have her emergency kit if something went wrong.
Yeah. So it's sort of like the EpiPen. It's not cheap to keep it around, Vitrace or hyaluronidase, but you always want to have it there and not use it like insurance policy. Can I ask you really quick, how do you dilute it? Do you do 1 to 10, 2 to 10, 1 to 5?
You know what? I don't dilute it. So
No.
if I'm dissolving something that's really, really superficial, I might do a 2 to 1, but I always keep mine is like full strength, so that if there ever was to be an arterial occlusion, that I could go after that occlusion with the potency.
Yeah. Yeah. For an occlusion, I agree. I'd go with the potency, but for like the eye bags, I'll do like a 1 to 9 or 0.1 to 0.9 for a 1 cc.
Okay.
But there's so many ways to do it. So, I mean, that's why you can see we do things differently, and there's many ways to get to where you want to go. So that's why as many training courses as you can go to if you're an injector, and also finding an injector who matches what you're looking for as well if you're a patient.
Yep. I agree with that. Well, I think that's going to wrap us up for today, unless you have any last words of advice for our listeners.
No, less is more, smile more.
I like that. What about you, Larry?
I like it too. I think that's a good way to end it.
Perfect. Well, thank you all for joining us, and thank you, Dr. Haley, for joining us today.
Thank you so much for having me. My last comment was, don't doctor shop. Stick with one person, as much as you can. That's the other thing.
Oh, yes. I like that one too. All right. Thank you. Bye-bye.
Bye.
Bye. Thank you.